very important for education. It's the same meeting I saw over the weekend. It's clear that patients who manage their blood sugar and measure their blood sugar have better blood sugars than people who don't look at their blood sugars. I saw a patient in the hospital yesterday put on metformin by her primary care doctor, which was perfectly appropriate. She did not send her for education, didn't tell her to measure her blood sugar, said, you know, we'll see you in 3 months. Patient didn't know anything about diabetes at all, just take this pill. I don't understand that approach. Pharmacists can help you out as well because they can help explain how some of these medications work if you have questions. And there are countless websites where you can get information which are certified and which give you appropriate information. If you're on a drug, every drug will have its own website which gives you more information about that drug itself. So, lifestyle interventions. For diet, we don't want you to eat anything. We want you to cut everything out of your diet. Just water. No. We want you to cut back on calories, which is the number one thing. We run a weight management program on top of everything else because after my doing this for all these years, you take patients who have been instructed in diet by the dietitian, they've been to the appropriate person, and 10 years have gone by and their weight has not budged 1 inch, 1 ounce from where they started. I've been on a diabetic diet for 10 years, I still weigh 230. I haven't gone up or down all that time. Well, that obviously is not an effective therapy. Decreased saturated fat. Remember, diabetics get heart disease, strokes, and circulation problems. This comes from the fat in the diet. Most patients with type 2 diabetes also have abnormal cholesterol or triglycerides or HDL, and those things come as part of the metabolic syndrome. So we're never just treating the sugar. We're treating the rest of the metabolic disorder. They often have high blood pressure as well, so we're talking about lower salt in the diet as well. 70% of diabetics have high blood pressure. 70%. And the diet has to be individualized. If I take a Hispanic patient and put them on, an American diet, they're going to ignore the whole thing because that's not what they eat. Bigger issue are Asians or Japanese or Chinese who live on rice. Everything they have has rice in it. It's all carbs. It's really hard to persuade these people to eat a diet that works. I have a Chinese doctor in the back, right? They all want to have rice. That's what goes with every meal, right? It's a challenge. And obesity in an Asian doesn't look like obesity in an American. A little bit of central obesity, a little bit of potbelly is all the same bad stuff in those patients as it is in our very obese Americans. See, they have the same metabolic bad problems. Weight reduction is obviously critical. So in our weight management program, if we put them on a low-calorie diet, we can bring down their blood sugars, their medications, in 2 weeks with a weight loss that might be 5 pounds, even though they might weigh 300 pounds. It's not how much weight you lose, it's how much you put in your mouth. You'll see a correction in glucose dramatically in a very short time before much weight loss occurs. Insulin resistance will disappear. I have a classic patient. The guy weighed 384 pounds when he first came. Hemoglobin A1C 9, which is an average blood sugar of about 250. On 150 units of insulin a day, taken in multiple doses. So we put him in our weight management program, and he lost 80 pounds, down to 304. He's still a huge guy, 304 pounds. His A1C went from 9 to 5.5. His average blood sugar on his meter was 72. And I took his insulin down from 150 units down to 22. He's still way overweight. That's how well weight loss works for those kind of patients. And we also make them exercise. We want them to burn 3,000 calories a week by exercise, which is, on the average, an hour a day. They're not running. 384-pound people are not running down the street. They're just trying to walk, trying to do something, pedal a bicycle, even seated, some kind of exercise. No one ever demonstrated that running was healthier for you than walking. As long as you do it for the same amount of time. Get your heart rate up a little bit. And obviously, stop smoking. Smoking and diabetes is a very bad combination. So this is an example of the same thing again. I'm not going to go through that. It's important to measure your blood sugar. So I just put a couple of packages in here. These are some of the current meters. They're actually new meters now. Somebody brought me a new meter this week that plugs into your iPhone, and then you can send your blood sugars from your iPhone or to your iPad or your iPod straight to me without having to even do any other kind of communication. And when you come to see me, for example, I will download your meter, print out the report, and be able to analyze the data to decide the best way to manage that fasting or that post-meal blood sugar. And you get this nice kind of graph. You really don't want to have these particular graphs for your patient. Blood sugar 500 over here, blood sugar 60 over here. That's more like a type 1 patient, not like a type 2 patient. These are all the major companies that make meters. So let's talk about, just for the last couple of minutes, the choice of medications that you might see. And I put this up here. These are the AACE guidelines. I belong to the American Association of Clinical Endocrinologists, and they have put together these guidelines which make the most sense to me. And their thought process is, let's decide what you need based on how high your blood sugar is. So all of these things assume that you have tried to lower your blood sugar as best you can with diet and exercise. So you've maximized whatever you can do as a patient with diet and exercise. But now you're still not at goal. The ACE goal is an A1C of 6.5. They want you to be better than the ADA wants you to be. There's reasonable data to suggest that the lower your A1C you can achieve safely reduces the risk of eye disease, nerve disease, and kidney disease. Not the same data for heart disease and stroke. So if your A1C is less than 7.5, you probably can get there with a single oral medication. At least the odds are pretty good. And they're all about equal. Metformin is usually prescribed first because it's been around for, well, it's been in this country for 20 years, been in Europe for another 20 years. We know all about this drug. We know it's pretty safe. We know its downside and its upside. And it does not cause weight gain. But again, as I mentioned earlier, it's not demonstrated durability of effect over time. So it's safe, doesn't cause hypoglycemia, doesn't cause weight gain, but it doesn't preserve beta cell function very well. The newer kids on the block, DPP-4 inhibitors, work by promoting that incretin deficit that I showed you way back on several slides. GLP-1 is a hormone made by the gut which stimulates the beta cell to make more insulin and the alpha cell to make less glucagon, so less glucagon, more insulin, but it does it in a glucose-dependent fashion. So if your blood sugar is normal, these agents don't work. They don't need to work. Your blood sugar is already normal. As soon as it goes up, they have an effect. So they don't cause hypoglycemia. They work when your blood sugar is out of line. So it's exactly physiologically what you would like to happen. And the data says that these kind of agents work even if you've had diabetes for 20 years, when you would have thought your beta cells had pooped out and had no chance of coming back to life. These agents can still revive them to some degree. DPP-4 inhibitors are oral pills. They're once a day. There are 3 of them on the market now. They're all brand name. They're all fairly expensive. I'm sure Ken has all the coupons that we have, but if you have Medicare, coupons don't work. So that's a big problem. GLP-1 agonists are injectable medications because you can't swallow them, they wouldn't get absorbed, they would get digested if you absorb them. GLP-1 agonists have the added benefit of working like the DPP-4 inhibitors, but they also cause weight loss because they decrease appetite. Not a lot of weight loss, 5 or 10 pounds on the average, but they also work well. And both of these classes of agents, presumably because they're helping the beta cell, helping the alpha cell, will preserve beta cell function for a longer period of time than old-fashioned drugs. We have data for 2 years, we don't have data for 10 years yet, but we think it's more likely to be beneficial.
How often do they have to be injected?
There are 3 on the market now, and there's a parade of them in research in our office. One is twice a day, one is once a day, one is once a week. So you have 3 different choices right now. And there's one that we're testing